Let's jump right into the Surgical Infections and Inflammatory Response Assessment. Question 1.
Macrophage response to microbes includes A. Genome-encoded pattern recognition receptors to invading microbes, meaning PAMPs and DAMPs. B. Upregulation of cytokine synthesis. C. Secretion of cytokines. Or D. All of the above. You guessed it, the answer is D. All of the above. So here's the deal. The response in macrophages is actually initiated by those genome-encoded pattern recognition receptors, think toll-like receptors, that spot microbial PAMPs and endogenous DAMPs. Once exposed, resident macrophages upregulate and secrete key inflammatory cytokines like TNF-alpha, IL-1 beta, IL-6, IL-8, and IFN-gamma right into the tissue milieu. Your absolute must-know exam pearl here. Macrophage response is initiated by these genome-encoded pattern recognition receptors.
Moving super fast to question 2. Which of the following is not a component of systemic inflammatory response syndrome, or SIRS? Is it A. Temperature, B. WBC count, C. Blood pressure, or D. Heart rate? Option C is the answer. Blood pressure. Look, SIRS is defined strictly by alterations in temperature, specifically greater than 38 or less than 36 degrees Celsius, heart rate over 90, respiratory rate over 20, or PaCO2 under 32, and white blood cell count. Notice what's missing? Blood pressure is simply not in that equation. Lock in this pearl. Blood pressure is explicitly not a component of SIRS criteria.
Question 3. The SOFA score. A. Includes AST and ALT. B. An increase in score of greater than or equal to 2 correlates with a 10% in-hospital mortality risk. C. Does not depend on lab tests. Or D. All of the above. B is correct. An increase in the cumulative SOFA score of 2 or more literally represents acute organ dysfunction and defines sepsis, directly correlating with a 10% or greater risk of in-hospital mortality. This is exactly what differentiates SOFA from Q-SOFA. The full SOFA requires lab data like bilirubin, platelets, and creatinine, whereas Q-SOFA doesn't. So your exam pearl? A SOFA score of 2 or more correlates with at least a 10% in-hospital mortality risk.
Hitting question 4. The best method for hair removal from an operative field is A. A razor the night before, B. Depilatory the night before surgery, C. A razor in the operating room, or D. Hair clippers in the operating room. The answer is definitely D. Hair clippers in the OR. Standard razors should absolutely be avoided because they create these microscopic epidermal nicks and abrasions. Those tiny cuts are basically perfect little niches for bacterial colonization, which significantly shoots up post-op wound infection risks. The absolute exam pearl for this one. Hair removal must only be completed using surgical clippers, and it needs to happen immediately prior to surgery.
Question 5. Source control refers to A. Drainage of purulent material, B. Debridement of devitalized tissue and removal of foreign bodies, C. Fixing the underlying cause of infection, or D. All of the above. D is the winner, all of the above. Source control is the primary, physical pillar of managing a surgical infection. It's a really comprehensive approach. We're talking about draining purulent abscesses, debriding necrotic tissue, pulling out foreign bodies, and directly repairing the structural defect that caused the contamination in the first place. The essential pearl to take away. Source control is the primary, physical pillar of managing any surgical infection.
On to question 6. Which of the following statements is correct? A. Most cases require only a single dose of prophylactic antibiotics given immediately before and during surgery. B. Infection can be prevented with 24 hours of prophylactic antibiotics. C. Empiric antibiotics imply the bacterial infection is a known bacteria. Or D. Empiric therapy should continue for 3 days only. Statement A is correct. Surgical antimicrobial prophylaxis is strictly limited to the window immediately prior to and during the operation. Extending that prophylaxis post-op honestly provides zero clinical benefit, drives up costs, and just promotes multi-drug resistance. Your high-yield pearl is that for the vast majority of standard procedures, a single preoperative dose of prophylactic antibiotics is totally sufficient.
Question 7. Which of the following factors does not influence the development of surgical site infections? A. Duration of procedure, B. Degree of microbial contamination, C. Malnutrition, or D. General anesthesia. The answer is D. General anesthesia itself is actually not an independent risk factor. Instead, SSI development is driven by the absolute degree of bacterial load, prolonged operative duration,
local tissue factors like hypoxia or hypothermia, and of course, patient comorbidities like diabetes and severe malnutrition. The pearl to lock in: standard general anesthesia is not an independent risk factor for an SSI.
Question 8. During an elective cholecystectomy, a large bowel injury was caused during trocar placement without spillage of bowel contents. What class of surgical wound is this? A. Class 1, clean. B. Class 2, clean/contaminated. C. Class 3, contaminated. Or D. Class 4, dirty. B is the correct choice. Class 2. Class 2 wounds specifically include cases where a hollow viscus harboring indigenous flora is opened under controlled circumstances without any significant or macroscopic spillage. Now, if there was gross spillage, it would bump right up to Class 3. The pearl: controlled entry into an indigenous flora harboring hollow viscus without spillage is always Class 2.
Question 9. Which of the following are not true? A. Postoperative hyperglycemia over 200 increases wound infection risk. B. Intraoperative hypothermia increases wound infection risk. C. High O2 levels during surgery increase wound infection risk. Or D. Hospitalized patients have a higher rate of wound infection. The not true statement is C. High oxygen levels do not increase the risk of infection. Actually, it's local wound tissue hypoxia and hypothermia that lead to higher SSI rates. To protect leukocyte function, clinical guidelines strictly say we've got to prevent hypothermia. Your exam pearl: always maintain perioperative blood glucose under 200 milligrams per deciliter and strictly prevent hypothermia.
Right into question 10. Which of the following is true about primary microbial peritonitis? A. Bacteria come from the intestinal viscera. B. Infections occur in patients with ascites and are monomicrobial. C. Infections are generally mixed gram-negative organisms. Or D. Generally requires laparotomy for sauce control. Option B is the true statement. Primary peritonitis occurs predominantly in patients with retaining ascites fluid or those undergoing peritoneal dialysis. The microbes literally translocate without a macroscopic break in a hollow organ. Since there's no gross defect, it is characteristically monomicrobial and can be managed successfully with systemic, targeted IV antibiotics. The pearl: primary peritonitis is monomicrobial and is managed without a laparotomy.
Question 11. The most appropriate treatment of a 4-centimeter hepatic abscess is A. Antibiotic therapy alone. B. Aspiration for culture and antibiotics. C. Percutaneous drainage and antibiotic therapy. Or D. Operative exploration and open drainage. C is your correct answer. Look, while tiny liver abscesses under 1 centimeter can sometimes be managed with antibiotics alone, larger macroscopic pyogenic abscesses definitively require combined source control and IV antibiotics. You can bypass the open operative exploration entirely. Your pearl for this one: the gold standard for large hepatic abscesses is minimally invasive, image-guided percutaneous drainage paired with IV antibiotics.
Question 12. Which is true about the treatment of pancreatic necrosis and infection? A. Enteral feeding is contraindicated until resolution. B. Pancreatic necrosis is an indication for early operative debridement. C. Open necrosectomy should occur in the first 2 weeks. Or D. Early enteral feeding via a nasojejunal tube beyond the ligament of Treats is associated with decreased development of infected pancreatic necrosis. D is absolutely correct. Initiating early enteral nutrition via that nasojejunal tube is super smart because it preserves the gut mucosal barrier and actively downregulates bacterial translocation from the colon. The pearl: early nasojejunal enteral feeding significantly reduces secondary infection in necrotic tissue. Hitting question 13 hard. Which of the following is not true of necrotizing soft tissue infections? A. 50% are polymicrobial. B. Elderly and immunosuppressed patients have increased risk. C. Can be treated with antibiotics alone. Or D. Is a clinical diagnosis. The false statement is C. Listen closely here. A necrotizing soft tissue infection cannot, under any circumstances, be treated with antibiotics alone. This is an absolute surgical emergency. It mandates immediate operative intervention for exploratory visualization and radical debridement of all infected fascia, fat, and tissue to halt the fast-spreading thrombosis. The pearl: necrotizing soft tissue infection cannot be treated with antibiotics alone. Immediate surgery is required.
Our final question, 14. Postoperative urinary tract infections. A, are usually treated with a 7 to 10-day course of antibiotics. B, initial therapy should be directed by results of gram stain or empiric patterns. C, are established by greater than 10 to the 4th CFU per mil in asymptomatic patients. Or D, can be reduced by daily irrigation. The answer is B. Initial management is always guided by gram stain results or local empirical patterns. And remember, it takes greater than 10 to the 4th CFU to confirm in symptomatic patients, but 10 to the 5th for asymptomatic. So, the crucial point in our final example, guide your initial post-op UTI therapy by empirical patterns and remove those Foley catheters within 1 to 2 days. Seriously, ask yourself on your next clinical rotation, is that catheter actually necessary, or are you just leaving a bacterial highway wide open?